overview of fasting blood glucose. For us that are practitioners, it's not new to us. So let me just quickly run through. So what I have here is that definition of blood glucose is, or fasting blood glucose is the one that is measured at least 8 to 10 hours of no caloric intake. 8 to 10 hours of no caloric intake. That's the one we consider as the fasting blood sugars. That is fasting overnight. And then for normal fasting blood glucose, less than 100 milligram per DL or less than 5.6 millimole per liter. For impaired fasting glucose, that is the pre-diabetes situation, occasionally 100 to 125 milligram per DL or 5.6 to 6.9 millimole per liter. And for a clear case of diabetes mellitus, fasting should be greater or fasting will give greater or equal to 126 milligram per DL, which is greater or equal to 7.0 millimole per liter on two separate occasions. So a single test of fasting blood sugar that is 126 is not diagnostic of diabetes mellitus. But if you repeat it at different times, and then you have equal to 126 or greater than 126, then it's an indication that the patient may be suffering for diabetes mellitus. So we use it for screening and for diagnosis of diabetes. We use it for assessment of glycemic control. We use it for pre-surgery evaluations, especially cases that they don't know their previous history about their diabetes mission or status. And then we use for monitoring the metabolic disorders. But it has a limitation. It can be influenced by stress, and it can also be influenced by illness. It can also be influenced by prolonged fasting or the use of certain medications. These are the limitations of the fasting blood glucose. So the second one I want to talk about is the random blood glucose. This one is measured at any time of the day without concern for timing of the last meal. And then for normal patients, the glucose level will be less than 140 milligrams for random, or less than 7.8 millimole per liter. And then for possible diabetes patient, it should be greater or equal to 200 milligrams. So the random of a possible diabetes patient should be equal to or greater than 200 milligrams per DL or greater or equal to 11.1 millimole per liter. And in this situation, there will be classic symptoms. Classic symptoms in possible diabetes patients are there will be polyuria, there will be polydipsia, weight loss, and blurry visions. So we use random blood glucose as a rapid assessment of hyperglycemia. And then we use it in emergency situations when the patient is in coma. The first thing we do, we check for the random blood sugar. Since he's in coma, we can't confirm whether the patient is fasting or not. So whatever you do at that time is considered the random blood glucose. So we use it also to screen when fasting is not possible. There are patients that can't fast. I've handled one like that before. I was to carry out OGTT on the fellow. And the fellow, by 3 a.m., the fellow will call me in the night and say, sir, I can't wait again. Oh, I have to eat. In fact, it took us almost a week before we were successfully able to carry out the OGTT. But the day I carry out the OGTT, I have to leave my house to attend to him at 6 a.m. in the morning. So there are patients like that cannot fast. So we use rapid random blood glucose to screen them. Limitation is that less accurate than fasting tests and should follow up with FBG or OGTT. Roy, is there other things you need to know about this? Okay, can we compare fasting glucose? It requires fasting, yes. Random does not require fasting. Diagnosis accuracy for fasting is high. That of random is moderate. And then fasting glucose is best for diabetes diagnosis, while random is due for rapid screening. And normal rate for fasting, less than 100. This is just a summary. For random, less than 140 milligrams. And then the threshold for fasting is greater or equal to 126, less or equal to 126 milligrams per DL. And then for random glucose, less or equal to 200 milligrams per DL with symptoms. So, and then I mentioned earlier some factors that affect the result food intake, like beverages, especially sugary one, physical activity and stress, illness or infection, steroid like beta blockers or oral contraceptives will affect result of blood glucose. Alcohol or sample handling errors can also affect our results. So these are possible factors that can affect the result of blood glucose. Now we have a complementary test to diagnose our inference from any of these investigations. One of them is hemoglobin A1C. We'll discuss that one fully later. And then we have oral glucose tolerance test too. We have insulin level and symptoms. These are complementary tests that can help us establish our diagnosis for the blood glucose level. And then the clinical features help diagnose diabetes or prediabetes, monitor therapy responses, detect hypoglycemia and hyperglycemia, and guide emergency treatment in acute cases. So these are the few things I want to share with us on blood glucose. Now, I want us to quickly look at glycogen storage. Glycogen storage. That's what we have in our outline. Glycogen storage. What is glycogen? Glycogen is the storage form of glucose in the body, primarily found in the liver, that is approximately 100 grams, maintain blood glucose between meals in the liver, and also found in the skeletal muscles, approximately 4 grams in the skeletal muscles, and it provides energy during exercise. Now, the glycogen or metabolism, the metabolism of glycogen, one of them is glycogenesis. Glycogenesis is the formation of glycogen from glucose. And the key enzyme in that process is glycogen synthase. Another metabolism of glycogen is what we call glycogenolysis. This one is the breakdown of glycogen into glucose 1-phosphate. And the enzyme activity here is glycogen phosphorylase. We've said earlier on that the site of glycogen storage is liver and muscles. Now we have some hormonal regulations that are involved. I've mentioned some of them. For insulin, promote glycogenesis in storage. Glucagon promotes glycogenolysis in the liver. And epinephrine, that's otherwise known as adrenaline, also promotes glycogenolysis in the muscle. We call it flight hormone. Now we have some disorders of glycogen. So let's quickly take them one by one. I mentioned them yesterday when I was talking about the overview of the general carbohydrate metabolism and disorders. So just in passing, we have von Ghake, whose defect is glucose phosphatase, and the organ is liver and kidney. We have Pompe, which is lysosomal acid alpha glucosidase defect. All tissues are involved. We have Cori, which is a result of the branching enzyme, also in liver and muscle. We have McDel, which is the muscle phosphorylase that is defected in the muscle. We have the hair, liver phosphorylase. Liver is the organ that it occurs. So, these are the summary of what I want to share with us on glycogen storage overview. Let's now go to insulinomia. Insulinomia. We look at insulinomia, the diagnostic criteria, and the laboratory investigations. By definition, what is insulinomia? It's a rare pancreatic neuroendocrine tumor. A rare pancreatic neuroendocrine tumor that secretes insulin. That is the portion of the pancreas that secretes insulin when it is infected or it becomes abnormal. When there's a tumor development, then we have this condition of insulinomia. Independently of glucose level causing recurrent hyperglycemia. It's independently of blood glucose level. It's a condition that does not really relate or depend on the level of blood glucose. It's a condition that will cause hypoglycemia irrespective of the concentration of glucose in the individual. Now, looking at diagnosis, classical diagnosis. Diagnosis of this insulinomia is suspected when the symptoms of hypoglycemia is shown. And I'm sure you are familiar with the symptoms of hypoglycemia. These are sweating, we have tremors, we have confusion and weakness. These are possible symptoms of hypoglycemia. So when these symptoms are noticed, then you go ahead and screen for insulinomia. And then when there's a documented low plasma glucose in a patient, low plasma glucose that is less than 2.5 millimole per liter or less than 45 milligram per dl in as a symptom, then you suspect insulinemia. And then sometimes when there's a relief of symptoms after glucose administration, relief of symptoms after glucose, that is you administer glucose and there's still hypoglycemia, then you suspect insulinemia. Now, what are the key laboratory investigations? The key laboratory investigations. Number one, we carry out 72-hour supervised fasting test, and it is the gold standard for insulinemia. So 72-hour supervised fasting test. So most insulinemia are detected within 48 hours. During hypoglycemia, that is glucose less than 45 milligrams, if insulin is less or greater or equal to 6 micro units per mil, then it is insulinemia. When you carry out C-peptide test and it is greater or equal to 0.2 nanomole per liter, then you confirm insulinemia. When the proinsulin is greater or less than 5 pmol per liter, you suspect it. When the beta hydroxybutyrate is low, you suspect insulinemia. When there's absence of sulfonylurea in blood, this definitely confirms endogenous insulin hypersecretion. Endogenous insulin hypersecretion. Now, additional laboratory test that is done is an insulin or glucose ratio of greater than 0.3. Insulin glucose ratio of greater than 0.3, and this is expected in a insulinemia. Then the serum C-peptide, if it's elevated above normal range, the proinsulin, the plasma glucose is less than 45 milligrams during attack. And then when the sulfonylurea strain and it is negative, that is the sulfonylurea strain is negative, then it is confirming insulinemia. When the beta hydroxybutyrate is suppressed, that is lower than normal range, then you are suspecting insulinemia. So if insulin is high or C-peptide is low, suggest exogenous insulin administration. But if both insulin and C-peptide is high with positive sulfonylurea, then we have factitious hypoglycemia. There are other localization studies, there are other methods of diagnosis after biochemical confirmation that can also guide. First line is the contrast CT scan abdomen, the CT scan of the abdomen. And this next one, you carry out the MRI of the pancreas. This one has a higher sensitivity to establish there's a tumor that can result to the insulinemia. And then sometimes endoscopic ultrasound is helpful, especially when the tumor is still small. Endoscopic ultrasound is useful. And also selective arterial calcium stimulation test is also used if imaging is negative. If the CT scan, the MRI, and the endoscopic ultrasound could not pick it, then we can screen for calcium stimulation test, that is selective arterial calcium stimulation test, SACST. This is useful. And then we also have what we call PET scan, dotatate, for neuroendocrine tumors, Other useful tests is chromogranin A, which is sometimes elevated in some neuroendocrine tumors, and genetic screening if multiple tumors familiar tendency is recognized. And then we also have what we call the insulin autoantibodies. You screen for insulin autoantibodies. If the autoimmune hypoglycemia, if autoimmune hypoglycemia is suspected, you screen for insulin autoantibodies. So, somebody is disturbing. Who is that? Oh? How is that? So that's insulinemia. The next thing in our outline mentioned, he said pancreatic hormones and glycosylated hemoglobin. Pancreatic hormones and glycosylated hemoglobin. I'm sure we know that the pancreas has both endocrine, that is hormone producing, and exocrine, that is enzyme producing functions. Endocrine is hormone producing functions, and exocrine is enzyme producing functions. So the pancreas has these two capabilities. So the endocrine part consists of the islets of Langerhans, which secrete hormones that regulate the blood glucose. The islets of Langerhans, they stimulate the hormone that regulate blood glucose. And topically, we have hormone like insulin, which are secreted from the beta cells of the islets of Langerhans, and this one promotes glucose uptake. It promotes glycogenesis. It promotes lipid synthesis, and also promotes the synthesis of a protein. I'm talking of insulin that is secreted from the beta cells of the islets of Langerhans. Another particular hormone is glucagon. This particular one is secreted in the alpha cells of the islets of Langerhans. And the function of glucagon is that it stimulates glycogenolysis, it stimulates gluconeogenesis, and also it stimulates lipolysis. That is glucagon. Another hormone that is also secreted by the pancreas is the somatostatin. That one is secreted from the delta cells of the islets of Langerhans. Somatostatin inhibits secretion of insulin and glucagon and growth hormone. It inhibits secretion of these three hormones: insulin, glucagon, and growth hormone. Another hormone that is secreted by in this portion of the pancreas is what we call the pancreatic polypeptide, the PP cells. It's secreted from the PP cells, the F cells of the pancreas, pancreatic polypeptide. And that one regulates pancreatic enzyme secretion and GI motility. Effect of another enzyme, before I talked about the effect of this hormone on the blood, is the one called ghrelin. Ghrelin is secreted from the E cells of the islets of Langerhans, and that one stimulates appetite. Effect on blood glucose. Ghrelin causes indirect effect on glucose via feeding, while pancreatic polypeptide causes minor effect on glucose. Then somatostatin, that is secreted from beta cells, that one regulates the balance of glucose. While glucagon raises blood glucose, insulin lowers blood glucose. That is for pancreatic hormones. Pancreatic hormones. Now, let's look at the glycosylated hemoglobin. Glycosylated hemoglobin. Now, we call it hemoglobin A1C. Hemoglobin A1C is hemoglobin that has glucose attached, but the attachment is a non-enzymatic glycation. It's a non-enzymatic glycation. So the attachment of glucose to the A1C portion of the hemoglobin or types of hemoglobin is gives us the understanding of assessment of glycosylated hemoglobin as a tool to diagnose diabetes in patients or diseases of glucose metabolism. So it reflects the average blood glucose over the past 2 to 3 months, corresponding to the lifespan of the red blood cells. The average lifespan of red blood cells is 120 days. So the glucose that is attached to the A1C of the hemoglobin, the red blood cell will carry that glucose for about 120 days. So when you now take the blood sample and you screen for the hemoglobin A1C, it will give you the percentage of the red blood cells that carries or that gets glucose attached to them for the past 3 months. Now, what are the clinical significance of glycosylated hemoglobin, otherwise known as hemoglobin A1C? Less than 5.7% is normal. Less than 5.7% is normal. And then for a pre-diabetes patient, it should be between 5.7 to 6.4%. And then for non-diabetes patient, it is greater or equal to 6.5%. I repeat, the clinical significance of hemoglobin A1C or glycosylated hemoglobin. In normal patient, it is less than 5.7%. In pre-diabetes patient, it is between 5.7% to 6.4%. And then in diabetes patient, it is greater or equal to 6.5%. Now let us look at the relationship to pancreatic hormone, that is the glycosylated hemoglobin relationship with a pancreatic hormone. When there is insufficient insulin, then there will be chronic hyperglycemia. And when there is chronic hyperglycemia, there will be increased hemoglobin A1C. That's the relationship. Another one is when there is excess insulin or effective treatment, then there will be better glucose control. So if there's a better glucose control, ultimately there will be reduction in the percentage of hemoglobin A1C. Another relationship is glucagon dysregulation. Glucagon dysregulation. When there is too much of glucagon, it can contribute to fatty hyperglycemia. And if there's fatty hyperglycemia, it will definitely increase hemoglobin A1C. So hemoglobin A1C is not influenced by short-term glucose fluctuation, making it a reliable long-time marker. It is not affected by short-time glucose fluctuation, not by short-time glucose fluctuation. So that is why it is reliable long-time marker in assessing the diabetes state of a patient. So that is the short note I have for. I will send the notes to you on pancreatic hormones and glycosylated hemoglobin. We also have in our outline lipid lipoproteins and apoproteins, their structure, their composition, and their functions. Lipid lipoproteins and apoproteins, their structure, their composition, and function. Maybe in an attempt to explain or define, lipids are known as hydrophobic or amphipathic molecules. They are known as hydrophobic or amphipathic molecules. And they include fats, they include oils, sterols, and phospholipids. So lipids are hydrophobic or amphipathic molecules that include fats, that includes oil, sterols, and phospholipids. They are key component of cell membranes and key component of energy storage of the body. So lipids are key component of cell membranes and key component of energy storage. Composition of lipid. From our background of fasting lipid profile, we have triglyceride. Triglyceride is made up of glycerol plus 3 fatty acids. We have phospholipid as a composition, which is glycerol plus 2 fatty acid plus phosphate group. We have cholesterol itself, which is a steroid nucleus plus hydroxyl group. And then we have others like fat-soluble vitamins. Vitamins like A, D, E, and K are fat-soluble vitamins. And then we have the glycolipids. So these are the composition of a lipid. Now, looking at the functions of lipids, basically for energy storage. In adipose tissue, we have about 9 kilocalories per gram of energy in adipose tissue. Structural, phospholipid and cholesterol in membrane, it functions as a structural backbone in membranes. So phospholipid and cholesterol gives a strong backing to the membrane. And then steroid hormones and eicosanoids are signals. So it functions as a signal for steroid hormones and eicosanoids. And then in subcutaneous parts, it assists in insulation and protection in a subcutaneous part. These are part of the functions of lipids, insulation and protection in the subcutaneous fat, energy storage, instill structural strength for the membrane, and then act as signals for steroid hormones and eicosanoids. Then we have lipoprotein. Lipoproteins. Lipoprotein are complexes of lipids and complexes of protein that transport hydrophobic lipids in the aqueous bloodstream. So lipoproteins are the complexes of lipids and proteins that transport hydrophobic lipids in the aqueous bloodstream. Now, if you want to look at the structure of lipoproteins, the core structure of lipoprotein is hydrophobic lipids. The hydrophobic lipids are triglyceride and cholesterol ester. Cholesterol ester and triglyceride are the hydrophobic lipids that are the core structure of lipoprotein. And then it also involves a surface monolayer, which is the aliphatic phospholipid or the free cholesterol. They are the surface monolayer. And then lipoprotein can also have a structural and functional proteins. You know, we have the embedded apolipoproteins, which serve for structural and functional proteins. That's the structure of a lipoprotein. And then by major classes, by density and function, we have the chylomicrons, has a very low density, composition is triglyceride and some cholesterol, and function it transports dietary triglyceride from intestine to the tissues. That is chylomicron lipoprotein. We have the very low density lipoprotein. It has a very low density, as the name goes, and then it is rich in T-glyceride and then some cholesterol. Function: very low density lipoprotein transport endogenous triglyceride from liver to the tissue. From liver to the tissue. We also have what we call the intermediate density lipoprotein. Intermediate density, it has an intermediate density, and composition is triglyceride and cholesterol. And function is VLDL remnants, which are converted to low density lipoprotein. Then we have low density lipoprotein 2. This one is a low medium density, and composition is cholesterol. And the function is that it delivers cholesterol to peripheral tissue. It delivers cholesterol to peripheral tissue. That is bad cholesterol. And then we have the high density lipoprotein. The density of this one is highest. Is highest density. And then composition is protein rich and cholesterol. And function of high density lipoprotein is that it reverses cholesterol transport to liver. It reverses good cholesterol transport to liver. So in summary, the functions of lipoproteins is transport of dietary and endogenous lipids, and then delivery of cholesterol to tissues, or reverse cholesterol transport, or supply of energy in case of TG to muscle and adipose tissue. So we have discussed lipids, and then we have discussed lipoprotein, looking at their composition, their structure, and their functions. Now we want to talk of apolipoproteins. Apolipoproteins. These are proteins that are proteins embedded in lipoproteins, are apolipoproteins. And they stabilize the particle and serve as ligands or enzyme cofactors. So apolipoproteins are proteins that are embedded in lipoproteins that stabilize the particle, and they serve as ligands or enzyme cofactors. So the major apolipoprotein that I want to look at now, and then we'll take them with their functions. The major, we can't mention or discuss all the apolipoproteins. So we're going to look at the major ones. The first one that we're going to look at is the ApoA1. And then the lipoprotein there is the HDL. And the function is that it activates SCAT. It activates SCAT structural. The second, that is ApoA1. The second apolipoprotein is ApoB48. The lipoprotein in ApoB48 is chylomicrons, and their function is the function in the structural aspect, and then in intestine, and it's of intestinal origin. That's where the function in the intestine of individuals. We also have ApoB100, and the lipoprotein in ApoB100 are VLDL and LDL. And their function is that they are ligand for LDL receptor. They are ligand for LDL receptor. Then we also have ApoC2. The lipoprotein in ApoC2 are chylomicrons and VLDL. And they are cofactor for lipoprotein lipase. They are cofactor for lipoprotein lipase. We also have ApoE. Lipoprotein in ApoE are chylomicron, VLDL, and ADL. This one has ligand for hepatic receptors. That is remnant clearance. The function as ligand for hepatic receptors. And then we have ApoA. ApoA. The lipoprotein here is the lipoprotein A. And its function is in the atherogenic. It has an atherogenic property in the structure. It has an atherogenic property, that is ApoA. Now, in summary, the functions of apolipoproteins: structural support for lipoproteins, activation of enzymes, recognition by receptors for uptake of lipoproteins, and then lipid metabolism regulation. So, for today, I want us to stop at this level. We have discussed pattern of random blood glucose overview. We have discussed lipid, lipoprotein, and apoprotein overview, their structure and their function and composition. We have discussed pancreatic hormones and hemoglobin A1C overview. We have discussed insulinomia diagnostic criteria, that is laboratory investigations, and then we discussed glycogen storage and glycogen storage diseases. So for today, I want to stop here. I don't know, tomorrow Sunday, Sunday is always a busy day for me. I will discuss with our class rep. So we'll plan for next week so that we can have another round of lectures so that we will be able to finish all our lectures on time. I'm sure by God's grace, if we can have, class governor, do we have plan to have lectures in the course of the week?
If you want us to do so, I'm readily available.
Because I want to finish this lecture on time so that before you finish on time, get your notes to you, and then prepare you for an in-course test to assess you, and then maybe also give you an assignment so that I can use the tool to do your CA and prepare you for the exam so that we can quickly put this 501 behind us. All right. Let me look at my schedule, the way my schedule will look like in the most likely Friday. Most likely Friday. So yes, I will look at my schedule, so I will get back to you. So maybe tentatively, let's have it that 6 p.m. on Friday. 6 p.m. on Friday, we may have our election. Is that okay by us, sir, for now?
Yes, sir.
Hello, yes, sir.
Thank you very much. Sir. So I will package our notes and send them to us.
Okay, sir. Well done, sir.
All right. Thank you very much. Do have a pleasant day.
Thank you, sir. Huh? Thank you so much, sir.
All right.
Thank you so much, sir.
We thank God.
Thank you so much.